In this video, we're going to discuss the different ways that someone can develop urinary incontinence, recognizing that only the first, stress incontinence, is unique to women, because you have to have a cardinal ligament and have had births in order to get it. What I want you to pay attention to is the symptoms, that is there an urge to void, and is there nocturnal symptoms? And then pay attention also to the diagnostic testing, the physical exam, urinalysis, and cystometry, recognizing when it is useful to do which test for which diagnosis. It becomes pretty clear, and it is actually siloed quite well, so you should not confuse these diseases for one another. So let's start off with stress incontinence first, because that's the one we've encountered already. Stress incontinence is a product of big or multiple births. When you have big and multiple births, what ends up happening is you stretch the cardinal ligament. The cardinal ligament is the thing that keeps the uterus, bladder, and vagina in place. So if you stretch it out after multiple births, everything becomes loose and floppy. What ends up happening is that you get a cystocele, such that when there's an abdominal pressure, that pressure is translated to the bladder, pushing urine out, but not to the sphincter, keeping it closed, as it does normally before the cardinal ligament gets stretched. So what the patient is going to present with, the syndrome she has, is sneeze and pee. And remember, you have to be an older woman who has already had multiple or big births that stretch the cardinal ligament. Anytime she increases her intra-abdominal pressure, she's going to leak. So whether it's sneezing, coughing, laughing, playing tennis, running, whatever, anytime there's an increase in the intra-abdominal pressure, a little bit of urine leaks out. Now there is no urge associated with this. And since she's not doing any tennis playing at night, there won't be any nocturnal symptoms. The diagnosis is going to be clinical. You're going to make it on physical exam. The physical exam is going to reveal a cystocele, and you'll have a positive Q-tip test. The Q-tip test is done by applying a Q-tip to the urethra, then having her increase her intra-abdominal pressure. If it rotates more than 30 degrees, you've got urethral mobility, indicating stress incontinence. Because this diagnosis is made on physical exam and with clinical symptoms, the urinalysis and the cystometry are going to be normal and therefore not needed. Since this has to do with a weakened pelvic floor from that stretch of the cardinal ligaments, what you can do is try to strengthen the pelvic floor. Kegel exercises are the very first thing to do, but these usually don't work, and so the intervention is going to then be pessaries. If bad enough, the patient will require surgery. Now, there's a number of ways to do this surgery, and they usually involve some sort of sling. But the one you're going to encounter, I think, the most is going to be the MMK and Birch procedures. You actually put the bladder back up, tack it where it's supposed to be, and this is more than a sling, it's colposuspension. To give you an idea of what this looks like, the normal patient is going to have both the sphincter and the bladder where it's supposed to be. That is, relative to the vagina, it's up in the abdomen. So that when intra-abdominal pressure is applied, it goes to both the sphincter and the bladder. In someone who's had multiple births, you're going to end up with a cystocele, such that the sphincter is now descended into the vagina, so that intra-abdominal pressure is not applied to the sphincter, but it is to the bladder, so urine leaks. Now this is the only condition that is unique to women, because you have to have a uterus, a cardinal ligament, and births in order for it to happen. The rest are going to be applicable to both men and women, but they're included in the GYN lectures because this is where they typically come up. Hypertonic motor urge, or as it's referred to on TV now in advertisements, overactive bladder, OAB. The fundamental pathology here is that you're going to have a hypertonic bladder. You're going to have random spasms of the detrusor muscle. The patient doesn't know when they're going to happen. There's nothing that sets them off. It just comes. This is going to be the person who's going to always be looking for a bathroom, who always has that urge to go, but every time they go, it's just a little bit. So the patient is going to have urge. And since random spasms happen all the time, it will be nocturnal. And they're going to leak with every contraction. Every time it contracts, they feel that urge. If they can't make it to the bathroom quick enough, they have a little bit of leak. Now, this is a motor problem. So the diagnosis is going to be made primarily on cystometry. The physical is normal. The urinalysis is normal, though it is usually gotten to rule out infection. And the cystometry is going to show the spasms. We'll see what that looks like in a minute. Since it has to do with spasming, the treatment is going to be antispasmodics. The medication you should look for is going to be oxybutynin. There are other medications, especially that are newer, especially the ones you'll see on TV, but because oxybutynin is old and cheap, that's the one you should look for. Now this is hypertonic. So the way you do cystometry is have the person void down to almost nothing. Then you allow the bladder to accumulate urine, and it'll reach a maximum level. You measure detrusor contractions through this process, and what you'll see is that you'll have random spikes of detrusor activity at all volumes. And it doesn't really matter, there's no pattern, they just happen. And so that makes the diagnosis of hypertonic or overactive bladder, and you treat it with antispasmodics. But you have to be careful. If you give too much antispasmodic medication, you can remove all detrusor activity, and you end up with the next condition, which is hypotonic, also called overflow or neurogenic bladder. And the pathology here is that there are absent detrusor contractions. Exactly the opposite of hypertonic. And the way you get the absence of detrusor muscle contractions is some severing of the neural system. Either the person can't feel that they are full to initiate a relaxation to contract, or there's a disconnect between the brain that says, I want a void, and the bladder actually doing the contracting. What's supposed to happen is the sphincter should relax and the bladder contract. Usually you do that when you feel the urge to void. In these patients, there either is no sensation of needing to void, or the signal to relax the sphincter and contract the bladder is disconnected from the brain. This happens in a neurogenic bladder. A neurogenic bladder can occur from multiple conditions, but you should look for MS, trauma, and antispasmodic medications. But the person is going to leak before the bladder explodes. And what I mean by that is, since they cannot empty their bladder, the bladder will fill, become quite large. But eventually, the wall tension of the bladder itself will exceed the pressure of the sphincter, and a little bit of urine will leak out. Once the pressure is relieved below that critical tension, the leak stops. A little bit more urine accumulates, exceeding the wall tension, leaks again. So what happens is the person has no urge because there is a neurogenic bladder. And there will be nocturnal symptoms because this continually happens unless you relieve the bladder. Now, it doesn't happen continuously, but it will be regularly throughout the day. And what I want you to feel is that this is going to be not something that's difficult to diagnose chronically. The person who is a paraplegic after a spinal injury or someone who has chronic MS, who intermittently caths themselves, has this condition, right? That's obvious. But what's not going to be obvious when someone presents for the first time. So look for the lack of urgent positive nocturnal symptoms that leaks regularly throughout the day and then has some sort of reason to have a neurogenic bladder. When you first make the diagnosis, the physical is going to likely show you a distended bladder. And you might find the focal neurologic deficit that goes along with the reason they have this neurogenic bladder. For example, the paraplegic in a wheelchair has no motor below the waist, or the person happens to have MS and has multiple neurologic conditions. In this case, the urinalysis is not going to be useful. It'll be normal, but it's usually obtained. And cystometry is how you get your answer. We'll talk about that at the end. The treatment, since this is a problem with absent spasms, is to induce spasm. You do that with bethanechol. But people who have chronic conditions that cannot be reversed are going to need something more aggressive. In this case, you're going to decide between intermittent versus chronic indwelling catheters. That is to say, someone will do catheterizations of the urethra intermittently at regular intervals so that they always drain the bladder. Now, to understand this, the cystometry is going to be done the same way. You drain the bladder, allow it to accumulate, and it reaches a maximum volume. And what you'll see is no contractions of the detrusor the entire time. This is usually not needed, right? Because you can get both hypertonic and hypotonic from the history. Just recognize that because these are issues of motor function of the bladder, cystometry is going to be the way you make the diagnosis. The next one is called irritative bladder. An irritative bladder is all about inflammation. And inflammation is going to come from stones, cancer, and UTI. This is not necessarily incontinence, but what happens is the person has an inflamed bladder, they need to go, and they may not be able to make it to the bathroom in time. This is the person who presents with frequency, urgency, and dysuria, and therefore there is an urge. And while these symptoms may wake them up at night, you're not going to have nocturnal incontinence, you'll feel the symptoms of the irritated bladder. Because it is an irritated bladder, the physical exam is usually going to be normal. The urinalysis is key here, which will give you the answer. White blood cells for infection and red blood cells for cancer or stones. And cystometry, being not a motor problem, is not needed. It'll be normal. The treatment is going to be based on the underlying condition. Right? For a UTI, you're going to give antibiotics. And the antibiotics you'll likely choose are going to be amoxicillin, nitrofurantoin, or trimethoprim sulfa. That's going to be discussed in the medicine videos in infectious disease. Stones will need to be identified either by some sort of imaging, and then you're going to need to strain to capture the stone in order to figure out what type of stone it is to modify the risk factor. That's talked about in the medicine videos under nephrology. And cancer will also need some imaging and then likely end up with surgery. This is discussed in the subspecialty surgery videos, urocancer. So I'm blowing through this one pretty quickly just to point out that the urinalysis is useful in irritated bladder and not really the other ones, and you only obtain that urinalysis to rule out stones, cancer, and infection when you're considering incontinence. The treatment here is going to be based on the individual diagnoses, and we talk about those elsewhere. We're going to close with fistulas. This is a continuous leak. A fistula is an epithelialized tract between two organs. And in this case, we're talking about the bladder to something else. And it can go to anything: bladder to skin, bladder to vagina, bladder to rectum. So what you have to look for is the reason why they might have a fistula. fistulas occur in inflammation and radiation. So look for someone who's had a surgery that went poorly, where a fistula could form, someone who might have malignancy, has or had, that is radiation treatment, or has inflammatory bowel disease, in particular looking for Crohn's disease. That's the way you get these fistulous tracts. And because a fistula is simply a tube between the bladder and something else, you're going to get a constant, continuous leak. But there will be also normal function. That is, the bladder still fills, they feel the urge, they can relax their sphincter, they can expel urine through the bladder and the urethra the normal way, but in addition, there's going to be a constant leak of urine. Now, if it goes to the skin, you'll just see urine leak out into the skin, and they'll usually have a pad or something to catch it. But if there's a connection to the vagina, you might end up with urinary leakage from the vagina. If it connects to the rectum, you might have stool in the urine, air in the urine, or urine through the rectum. So it depends where the fistula goes to the symptoms that it'll present. The diagnosis is going to be made first on the physical exam, where hopefully you'll be able to see the fistula. Because what you're looking for is a fistula, the urinalysis won't be useful, and the cystometry won't be useful. You might find that there's feculent material and a lot of bacteria in the bladder, but that won't tip you off that there's a fistula until you do some sort of assessment, and that is the tampon test. You put the tampon where you think the exit of the fistula is, the vagina, the rectum, or the skin. You inject blue dye into the urethra, into the bladder, and then you wait to see where the blue dye goes. Wherever the blue dye ends up on the tampon, you've got a fistula. And if you have a fistula, the treatment is surgical resection, a fistulotomy. Right, we talked about 5 different causes of urinary leak, that is incontinence. The first one, stress incontinence, is unique to women because you have to have big multiple births to stretch the cardinal ligament. Sneeze and pee, don't need any type of testing. Physical exam gives you the answer. Strengthen the pelvic floor. Hypotonic and hypertonic are the opposite to each other, and since they are muscular disorders, use the cystometry to find out which one it is. Hypertonic is going to have random spasms whenever they want, so lots of urgency and nocturnal symptoms. Treat with antispasmodics. Hypotonic is going to be the person who has a reason to have a neurogenic bladder and will need intermittent catheterizations if you can't use Bethanechol to push them through it. Irritative bladder is UTI, stone, and cancer. Use the urinalysis, and that's where the urinalysis is useful. And lastly, fistulas are going to have a continuous leak because there's a connection between the bladder and something else. Identify where that connection is with the tampon test and cut out the fistula. That is urinary incontinence.